Hello, everyone. My name is Dr. Hussein Kachwala. I'm from Mercy Health St. Rita's in Lima, Ohio, and I wanted to talk to you about the successful medical management of core triatrium sinistrum, or essentially a heart with three atriums. Core triatrium sinistrum is a rare congenital heart defect with an estimated incidence of 0.1% and occurs when a child is born with thin fibromuscular membrane subdividing the right and left atrium into three chambers. The pathology is associated with other congenital heart defects such as ostium secundum and total anomalous pulmonary venous return. In core triatrium sinistrum, the left atrium is divided into two distinct chambers: a posterior superior chamber, which receives the four pulmonary veins, and an anterior inferior chamber, which is the true left atrium. Core triatrium sinistrum classically presents in infancy. However, cases can go undetected until adulthood, such as this case. The addition of another chamber in the left atrium can mimic other cardiac diseases such as mitral stenosis due to the obstructive properties of the additional atrial membrane, and ultimately creating an increased pulmonary venous and atrial pressure. So in this case, a 70-year-old man with a past medical history of coronary artery disease, status post-CABG, hyperlipidemia, hypertension, and asthma presented to the emergency department with complaints of non-radiating chest pain that was fast and irregular at 150 beats per minute. EKG showed SVTs with Q waves in the inferior leads. He received 6 milligrams of adenosine with an additional 12 that finally resolved his arrhythmia, and a decreased heart rate to 87 beats per minute. Troponins were negative at the time, and the patient was admitted for further evaluation. On chart review, an echocardiogram from 2013 showed 50% ejection fraction, while his current transesophageal echocardiogram showed severe cardiomyopathy with an ejection fraction of 25 to 30%. He had euvolemic right-sided pressures, severe mitral regurgitation, and an incomplete porous membrane allowing for communication of the pulmonary venous atrium and mitral atrium. Left and right heart cath was unremarkable at the time. On discharge, he was referred to a heart failure clinic and was started on a goal-directed medical therapy for severe systolic heart failure, NYHA Class 2. He was also given a life vest with a 30-day event monitor and a follow-up TEE in 3 months for consideration of an implantable cardioverter defibrillator and a mitral clip placement. His medication include rivaroxaban, Entresto, Toprolol, Lasix, aspirin, Farxiga, and clopidogrel. A month later, he revisited the ED with lightheadedness, and a repeat echocardiogram showed an increase in ejection fraction to 35 to 40%. Rivaroxaban was discontinued at the time, and 3 months later, he came back to the outpatient clinic, and an echocardiogram was again conducted, which showed an ejection fraction of 50 to 55%. His symptoms were resolved, and the mitral clip placement was discontinued. In this case, we illustrate the potential for ejection fraction recovery in medically managed patients despite having core triatrium sinistrum, suggesting that septal resection is not always necessary. This is a congenital malformation with the normal fibromuscular septum dividing the left atrium into two separate chambers and potentially obstructing blood flow into the left ventricle. Recent studies suggest that the role of hydroxylase 2 deficiency is in the development of these fibromuscular membranes, and these are commonly associated with other septal defects to allow for the continuity of life. In this case, however, the patient's heart had no such thing apart from the limited blood flow between the two atrial chambers. With this patient having congestive heart failure with isolated core triatrium sinistrum, a possible pathology in the worsening of his symptoms could be due to the supraventricular tachycardia, which could have led to an atrial fibrillation-induced cardiomyopathy, leading to further dilation of the left atrium. This is most likely leading to a cyclic pattern of overall decompensation. Another factor to consider is the decompensation and rapid resolution with medication is the various presenting anomalies of core triatrium sinistrum. There have been multiple theories proposed, including malincorporation, entrapment, and malseptation, which leads to different abnormal growth of the atrial septum. These are further classified by the Lucas and Crabel model into type 1, 2, and 3. Type 1 suggests that there's an accessory left atrial chamber where the pulmonary veins communicate with the left atrium. In type 2, the pulmonary veins do not communicate with the left atrium. In type 3, there is also known as subtotal variant, where the pulmonary veins communicate with the left atrium while some communicate with the accessory chamber. Our patient was likely type 1 and hence remained asymptomatic secondary to his febrile anatomy. As our goal-directed medical therapy included prevention of his arrhythmias, this likely increases responsiveness to cardiac reformation and improvement in ejection fraction. Hence, he did not need any procedural interventions. The rarity of this congenital malformation does not warrant formal guidelines for treatment. In addition, we did not see documented evidence for deciphering what kind of medical versus surgical management can be most beneficial for each patient. Our case does show that a patient with adult onset symptoms can show rapidly improved ejection fraction in the span of 2 months, allowing him to entirely avoid surgical correction. With the growth of diagnostic modalities and the evidence-based medicine supporting various goal-directed medical therapies for many conditions over the years, one can be hopeful that the non-invasive option exists for these patients with such rare conditions in adulthood.